right. I've been asked to speak about this, and I'll probably a lot of it has been covered and by excellent talks earlier. So there may be a bit of overlap because I realize that the concepts are broadly the same. So of course, no, perfect corneal surgery no longer utopian, and getting 6x6 vision in a standard virgin cornea like this with a good preoperative workup works quite well. But there are some factors which need to be taken into account which affect the biometry. And for us, I think an important part is what is the power of the glasses or contact lenses they use, because I call this the optimization of vision by the patient itself. So they've already used and refined their own glasses. So if they're using a higher cylinder on the glasses or contact lenses, we really need to take that into account because it may compensate for the intralenticular astigmatism beyond the corneal level. There are some factors on the cornea, which is the excimer, PRK, or LASIK, or an ocular surface, because these affect measurements. There are some factors in the cornea, like intracorneal rings, post-keratoconus, you have keratoplasty, and of course, some factors beyond the cornea, which is phakic lens, previous IOL, if you're doing a secondary IOL, and an effective lens position. Now, there are some critical factors which help to achieve perfect outcomes, which is getting 20/20. One is, of course, keratometry, which has been fairly well stressed on earlier, important in ecthesias and definitely post-refractive surgery. Axial length, extremely important, probably with the present optical biometers, repeatability in up to grade 3 cataracts is actually quite good. Now, the effective lens position is something that is a prediction. Remember that it is a prediction, and it varies with patient systemic factors, sometimes changes with capsular phimosis, even capsular laxity can change the effective lens position. And that's something that is still a predictability. When you're doing IOL power calculation in irregular corneas, there is, of course, the refractive index error. There are errors in the corneal keratometry values. That now, which has been stressed down, is the change in relationship between the anterior and posterior curvatures of the cornea. And of course, there are inherent difficulties in various IOL formula that are actually being used. Myopic ablation, I think already fairly well covered, leading to an underestimation of the final IOL power because of the change in the keratometry. You can also end up using artificially lower keratometry values, and you also underestimate the effective lens position. Ectatic corneas, which Dr. Vavikar already covered, may have higher axial lengths, deeper anterior chambers, making the effective lens position even harder to estimate. Now, remember that steep keratometry values will overestimate the IOL power. And when we are looking formulas which work in keratoplasty eyes, it's important that you take into consideration axial lengths. So, formulas which consider axial length more include Hoffer-Q and Haggis. Now, in ectatic corneas, remember that the keratometry values in ELP are overestimated. Hence, the IOL power shows a hyperopic shift. Almost always, of course, most of us have shifted to third to fourth generation formulas and optical biometers. Remember, especially in post-corneal procedures, the optical biometry may be actually off-center. So the visual axis and something about alpha and kappa, which has already been mentioned, will change. And this is important even something like post-intracorneal ring segments or collagen cross-linking. Now, there are some pointers for keratometry. Remember that if the apex is off-center, it may not be in the visual axis. This means that the corneal keratometry measured in the apex may not be the K we have to use for calculation. But usually beyond 0.5 millimeters is when it really makes a difference. Less than 0.5 millimeters, it would not make a difference. Remember also, we have to decide the optical zone that we are going to use. There is no specific rule as of what I have read to decide how large the zone should be, but most people use about 4 millimeters. But remember, if you go for larger optical zone, this will overestimate the case because there would be an average of the K values. Now, the present accepted modality is to take the EKR values in the central 4.5 millimeters, obtained in the pentacam or any other shine plug image that you have. And this seems to be most accurate for in irregular corneas. You can take an average of that if this is used even for post-RK or for any other refractive surgery. Now, when you have a patient with a previous corneal graft, endothelial count in topography is of course mandatory. You may prefer to remove the sutures, but I have done patients like the patient on the right with continuous sutures, not having to actually remove the sutures if it's a very regular topography. Remember that most sutures can be kept in even for 1 year, though most corneal surgeons start removing them after 4 to 6 months to adjust the astigmatism. But the double continuous sutures, which I routinely do, I find that you can keep the sutures in even up to 2 years post-surgery. The second important part is in terms of sequential versus simultaneous surgery. Now, I have done more in a couple of patients in which we had doubts with respect to the effective lens position and the biometer values. We have done sequential. While we remove the cataract, leave the patient aphakic, get them back in a week's time, repeat the axial length measurements, and then go ahead and implant the lens. And that actually gives very, very good predictable results in these slightly unpredictable eyes, especially post-keratoplasty. Simultaneous surgery, if you have got, if your good axial length measurement correct, especially in early cataracts, this is a preferred option. Of course, surgical technique includes a limbal incision, avoiding the graft hole junction, a medicalist technique with viscoat, and of course, slow motion phaco-parameters. Now, there is enough data now on normal virgin corneas. So we know that almost all machines really agree with each other in terms of the keratometry. There is no significant difference in all the three, even the advanced levels of optical biometers. And there is high comparability between K1, K2, astigmatism, between all the predominantly corneal-based imaging lens machines. But in complex corneas, there is some difference. Diseases that alter the posterior corneal layer, example, ectasia, post-keratorefractive procedure, the Placido image that measures only the anterior surface may fall significantly short in measuring the true corneal power. And true corneal power is an important part when you actually calculate the IOL power, post-keratoplasty, or even something like post-corneal rings. Now, Scheimpflug-based systems, the SIMK readings overestimate the total corneal power, especially in advanced keratoconus, and this discrepancy proves the source of the hyperopic refractive error after cataract surgery. So almost always you would need to take into account the posterior corneal power in most cases. Just for an example, and this is an ectatic cornea, who came to us for cataract surgery, and he had some kind of laser ablation. We were not really sure 20 years back. And if you look at both the eyes, fairly symmetrical. Now, when you look at the K readings, and we did almost across 4 machines just to make sure we're not missing anything. We did the autokeratometry, we did the SIMK, IOL master, pentacam, and posterior curvature. And you can make out that there is almost about half a diopter, 1 diopter difference between different machines. But the Cirrus and the pentacam tend to agree because they use predominantly the same technology. If you compare the left and right eyes, of course, the IOL masters in some very extreme cases were not actually giving us correct results. So when you compare the left and right eyes, there is an agreement between the Cirrus and the pentacam, and then we decided that we would actually use that as the base for the keratometry. If you look at other measurements, antechamber depth, you look at IOL master variability, you have lens thickness variability. Axial length is something that we decide to go with the optical biometer. So your source of the keratometer is always going to be Scheimpflug-based imaging. A source of the axial length needs to be optical biometers. And when you look at powers, and there is such a lot, and we did all this just as an exercise. We did the Barrett Truquet, we used the IOL master, we used the Hollywood Toric, we used the ASC online Shamas, Hagizel, the Hill Pentacam, the Barrett Truquet, even the ASC average IOL power. And once we put all of this together, just to make sure, just as an exercise, what we would get, this was the final conclusion when we looked at all the combinations, where we looked at effective corneal power, predicted corneal astigmatism, toric canal. We used the universal toric. We decided that final, you really, if you want to look at the most important slide, I would put it as this, where you look at the EKR, you measure the measured posterior corneal astigmatism, you take the toric K, you take the axial length from the IOL master or any optical biometer, and then decide. And for that patient, we put in slightly different powers. And of course, we optimize the second eye based on the first eye results. So for me, EKR, measured corneal astigmatism, and the Barrett toric is probably the best combination available. This is just a short video on a customized toric and IOL post-keratoplasty, and he had a mature cataract. In this, we have, of course, almost removed all the ends. He's got a fairly mature cataract. In these patients, this was a fairly old video, almost about 4 years old. But if I had to do him again, I would probably do a sequential. Now, just a pointer, and this is, of course, not exactly related, but in terms of using the technique, remember, a lot of them post-therapeutic keratoplasty tend to have a membrane. So we actually just wanted to excise the membrane. You can see the pigments on the anterior capsule, and you may not actually perfectly get a perfect round rhexis in these patients. This very soft cataract, we basically did the rhexis in two parts, did the toric marking, and then basically inserted the IOL as per axis. Of course, here we had a customized toric from Zeiss, and it worked actually quite well. Now, the advantage with a smaller rhexis, of course, it is actually very, very stable. And the principles in terms of measurements, here we, at that time, usually had to have only one measurement. So it's not that it's critical, but it's an important part of getting the postcorneal curvatures. This was also just to mention that if you're lucky, you can get a post-RK patient with a fairly regular astigmatism, and we actually did a multifocal toric in these lenses. So if you follow these processes, I think it actually gives quite good results. Of course, post-operatively for this patient, the hospital were happy with the income, and I was happy with the outcome. Just the last couple of slides to take home. There's no single formula that is reliable. Most repeatable values have to be considered. So if you have the access, and we actually send the patient to multiple centers to get that, the second eye surgical data may be calculated based on the post-op refraction of the first eye, in case there is bilateral need for surgery. I would end. In terms of the keratoplasty, I think I've covered, because pterygium was a tricky part, and if there's any points for discussion, we can take it up with it. Thank you so much for inviting me.